start your moderator?
Yes. So I guess you are the next talker, correct?
Yep.
Yes.
And I'm pleased to see your talk about endoscopic fusion techniques of the spine.
Okay.
And later on, then I will give an overview about endoscopic surgery. And then I hope that in the end, we have a good interactive discussion about where we stand with all what we heard so far and what we can do in the future. So please go ahead.
Can you see my slide?
Yes, very well.
Okay. Thank you so much, Dr. Benedikt and Professor Mehmet Cirelli. This session is my session is that the endoscopic fusion, and this session is the endoscopic spine surgery. Is it the new standard? I'm also performing the uniportal full endoscopic spine surgery more than 20 years, and today I'm talking about that the endoscopic lumbar fusion will be the next generation. Okay, this is my curriculum by 10 disclosure. Yes, currently the people's mean life increased so much because of that some increasing the lumbar stenosis and that need some decompression and fusion increased so much. Because of that, there also will be the medical problem in the future. Maybe so many patients that they need some recover their normal life and normal activity. And fortunately, endoscopic spine surgery developed so much, and we already well known that it may be divided in two generations of endoscopic discectomy, and first generation of transforaminal, second generation of intraminal. And now we going on the third and fourth generation of the endoscopic decompression and endoscopic fusion generation. And now also we so many instruments and equipment also developed sufficiently to support this endoscopic decompression and fusion. This is my data of my clinic during last 1 year. Here we can see the very important data is that with performing the well decompression, well discectomy, and well decompression, not only lumbar but also thorax and cervical, and also for the lumbar interval fusion, that we can perform the near all patients can possible endoscopically. This 1,700 cases of during last 1 year, we only performing 4 cases of open surgery, 2 here, HDF with the cervical myelopathy cases only. Another all patients can possibly managed by the endoscopically for decompression, discectomy, fusion, cervical myelopathy, and thoracic myelopathy, and foraminal stents, all things. And now we checking the endoscopic uniportal endoscopic lumbar interval fusion. But here we can see the 3 endoscopic approach currently introduced. That firstly, transcambient approach introducing, but nowadays they're introducing the intraminal approach and the paraspinal approach together. And I mainly use this paraspinal approach. There have 10 surgical steps of the endoscopic lumbar interval fusion, and also endoscopic lumbar interval fusion mainly similar to the transforaminal open lumbar interval fusion. Because of that, the technique is near similar to the open transforaminal lumbar interval fusion. Here we summarize that the 10 surgical steps of the endoscopic posterolateral transforaminal lumbar interval fusion. There have the here you can see the step 2 finding the Kim's point in the endoscopic lumbar fusion. First important step will be the some resection of IAP and resection of SAP, then the opening the transforaminal space. Because of that, how much we can decreasing the operation time to resect the SAP and IAP will be very important. Before we use the from conventional medial to lateral resection technique for IAP resection, but there is sometimes a long time operation time. But if we use the Kim's point, this Kim's point already published in the paper of the brain science by me, and we using this technique of the IAP resection, SAP resection also similar resection procedures. Then we can decrease in the operation time so sufficiently. Now you can see the next step of the IAP resection. I already mentioned that first researching the Kim's point and resect from medial lateral to medial IAP pars portion, then remove the resected IAP, and then SAP resection also similar procedures from lateral to medial. And this line also find from above the pedicle above line, then you can resect SAP sufficiently. After then, we can expose the transforaminal area. Next step of the two step will be very important tips of the endoscopic lumbar interval fusion. You can see here there's some chronic adhesive disc in the opening. After opening the transforaminal area, we can find the disc area. Then so many patient cases we can see the so collapsed disc space. Then make some focal segmental collapse and sometimes discrete collapse. If we sufficient restoration, that point will be the success of the endoscopic lumbar interval fusion and also success of the correction of the spinal alignment. And also, next step is the some after chronic adhesive disc drilling. Then next step is the end plate denudation. This is also a very important process of the endoscopic lumbar interval fusion. You can see here the end plate denudation without damaging the end plate. This is very important to achieve the sufficient fusion rate and sufficient decreasing the substance rate. There is a main goal of the endoscopic lumbar interval fusion, like open lumbar interval fusion. Because of that, this process also very, very important process. And the next step will be the some before time some delivering of the KG to the target point is a main worry of the endoscopic spine lumbar interval surgery. But fortunately, currently, I introducing this Harrison cage glide. You can see here, Harrison cage glider for protecting the traversing nerve root here, exiting nerve root together. Then first insert like this way of the vertebral body, and you can see here the disc space, and then rotate insert into disc space. Then you can see here again pushy and insert the follow the obturator and then insert and rotate. Then you can insert the cage to the target point like this method. Then next step will be to insert the cage to the target point like this way, like this, and the final screw. This postoperative skin image of the endoscopic lumbar interval fusion. And also currently many paper published for the scientific basis of the endoscopic lumbar interval fusion. You can see here the paper published by me. I already mentioned that the Hyeun-Sung cage glider maybe protects the traversing and kicking nerve root. Because of that, we can safely deliver the cage to the target point in spite of the very small working space. And also this using the Kim's point, we also can decreasing the operation time. Maybe usually my operation time of the skin to skin for one level lumbar interval fusion usually need less than 1 hour or 2 hours, usually 1 hour 30 minutes. And also this paper published by me in the Global Spine Journal talking that the fusion rate and more rapid and more sufficient fusion rate can take in the endoscopic lumbar interval fusion. And also substance rate also more decreasing compared to the open transforaminal lumbar interval fusion. And also I already mentioned that maybe in the endoscopic lumbar interval fusion, very distinctive techniques of the these two techniques, chronic adhesive disc drilling and end-plate dentation, is a completely different and distinctive technique compared to the open transforaminal lumbar interval fusion. That will be main advantage of the endoscopic lumbar interval fusion. And also using this chronic adhesive disc drilling, I already mentioned that in the cases of chronic focal segmental collapse so severe and disc collapse so severe, spondylolisthesis so severe, also in these cases also can take a sufficient restoration of focal segmental correction, sufficient restoration of disc height, sufficient restoration of the spondylolisthesis can possible. This also already published in the paper by me. This is very important to performing the endoscopic lumbar interval fusion for the degenerative cases for malalignment spinal alignment cases of degenerative scoliosis, sometimes degenerative kyphosis cases. For example, this case is using this technique. You can see here cases so severe collapse in the L5S on disc space. In this case, it's before time. This is not in the posterior approach. Because of that, many doctors try the anterior approach to restore this case severe collapse and spondylolisthesis restoration sufficiently. But because of that, some third operation risk also increase some more compared to the posterior approach. Because of that, if we can possible by the endoscopically like this way and like this, then the patient, we can more safely and more sufficiently restoration of the patient's result, and then make then meaning that the more good clinical result to the we can give a more good clinical result to the patient. Also, similar cases of like this also in the L5S spondylolisthesis cases need some large, some sufficient restoration, and larger angle maybe need some sufficient spinal alignment correction. But in the previous concept, open surgery, this is not in the posterior approach. Because of that, it needs some anterior approach. But nowadays, using the endoscopic lumbar interval fusion, we can restore sufficient and we can give the sufficient angle, and sufficient restoration is all possible by the chronic adhesive disc drilling technique. For example, like this cases of some very difficult cases of the spondylolisthesis L5 and L5S on retrolisthesis, so severe case, because of that, in these cases, the posterior approach will be not in the open approach. Because of that, maybe need some another additional technique. But if we can possibly by the chronic adhesive disc drilling to apply these cases, also we can take like this result. You can see the sufficient restoration of the L4-5 and L5S together, and also spinal alignment also corrected very successfully. And I already mentioned that using this chronic adhesive disc drilling and end-plate denudation and the 3D printed KG, then we can, nowadays we can take a more sufficient fusion compared to the open transforaminal lumbar interval fusion, then meaning that the more good, we will give a more good clinical result to the patient. You can see this image take on only 2 years. Because of that, using these several techniques of the endoscopic lumbar interval fusion, nowadays we can apply the for degenerative scoliosis cases, and I'm also already published this cases in a paper, World Neurosurgery. You can see here the degenerative scoliosis corrected sufficiently after operation. Chronic adhesive disc drilling technique. For example, like these cases, for all the patients maybe degenerative scoliosis, they need some correction of several segments, and this also loss of spinal alignment together. But if we can possible using the chronic adhesive disc drilling, endoscopic lumbar interval fusion can take a sufficient restoration of spinal scoliosis and spinal kyphosis together. And also this case is also pelvic surgery cases also looks like very difficult cases and degenerative scoliosis. But using the endoscopic lumbar interval, you can see here and here, then you can see the sufficient correction is possible. And also the patient can take a sufficient spinal alignment correction, and then meaning that the patient real excellent clinical result to the patient, and then meaning that the patient can return to normal life more sufficiently. And also using this technique, currently we can apply to the degenerative kyphosis cases. You can see here degenerative kyphosis for, and try the 3-level lumbar interval fusion by the endoscopic lumbar interval fusion. Then post-operatively, you can see some correction, but 6 months and 1 year later, the patient's spinal alignment corrected near completely. And also, like because of this advantage of the endoscopic lumbar interval fusion, nowadays we can more successfully apply to like this degenerative scoliosis and kyphosis cases like this way. And also nowadays we also tried a more new trial for new endoscopic spinal surgery. For example, fortunately, using this endoscopic spinal surgery can decrease the blood loss. Because of that, during last 1 year of my clinic, of 190 cases of endoscopic lumbar interval fusion, we have no intraoperative transfusion, only postoperative and preoperative transfusion only. This is very important for geriatric generation, because of some transfusion, also maybe sometimes maybe some danger. You can see this patient also have no transfusion during the operation. After operation, only 1 pint transfusion only. And because of that, nowadays we can possible to, in spite of the endoscopic lumbar interval fusion, no open surgery, no general anesthesia, no suture, no dressing, no transfusion is possible. And also we try to decreasing the infection rate in the endoscopic spinal surgery. And also you can see here this 85-year-old male patient for they need fusion surgery. And after operation, you can see the sufficient success clinical radiological result. And also, currently we try to the large angled cage in the posterior approach. Like this large angled cage in the previous concept, it only can insert in the anterior approach is possible. But nowadays, using the chronic adhesive disc drilling can take a sufficient disc distraction is possible. Because of that, now that we can insert, in spite of the larger angled cage, insertion is possible. For example, like this cases, this patient received the L4-5 interspinal device before, but now L5 severe collapse. Because of that, this patient needs some correction of the L5S1 angle correction that maybe needed. This patient needed. Using the chronic adhesive disc drilling, we can take like this excellent clinical result with a large angled cage. That meaning the spinal alignment also corrected more sufficiently, meaning that the patient can possibly more sufficiently return to their normal life. For example, like this case is also received the two-level fusion decompression before. After then, the patient take a failed back surgery cases. You can see L3 spondylolisthesis, L4-5 listhesis. Because of that, if we hope to successful surgical result to this patient, we need some larger angled cage for L3, for L4-5. Because of that, maybe before time, this case need try to the lateral approach or anterior approach. But if we try to insert it using the chronic adhesive disc drilling, we can insert like this larger angled cage insertion is possible. Then the patient can possible sufficient spinal alignment correction is possible. And currently biportal surgery also can 3D large angle cage insertion also can possible. And also now I'm also thinking that in spite of the excellent clinical endoscopic spine surgery can take us excellent clinical results, there more need sufficient rehabilitation after operation, and I'm trying to skywalking system for so many geriatric patients and so many fusion cases patients. And then using this process, in the cases of long level fusion cases, we can see because of that endoscopic spine surgery, preserving all structures of the skin and all structures. Because of that, you can see here that in spite of long level fusion, the patient have a spontaneous restoration effect. I'm thinking this concept maybe keep the tensegrity, make some like this spontaneous restoration effect in the spinal segment. Fortunately, like this development of the endoscopic spine surgery, you can see this patient maybe received a long level fusion for degenerative kyphosis, and you can see still the failed back, and the patient come to my clinic with a near complete pelagic state. You can and then you can see this so severe cord damage here, but using endoscopic spine, endoscopic lumbar fusion with the chronic adhesive disc drilling, and with some skywalking system of rehabilitation system, you can see after operation, we removed all this area, only fixation only 2 years, short segment fixation. In spite of them, post-operative and post-operative whole spine looks like not completely restored, but after then rehabilitation doing, and then 1 week later, 2 weeks later, 3 weeks later, and the patient also have a more good recovery. She's working, and then 4 weeks later, the patient fortunately can pass over by himself only. In conclusion, I believe that in the future, the spinal surgery also will be developed so much, and we will to the target of the robotic surgery and next generation of spine surgery. But I believe that all this process may be based on the endoscopic spine surgery, and also success of the endoscopic lumbar fusion is the key to success of the whole degenerative spine by the endoscopic spine surgery. Thank you for your kind attention.
Thank you. Very nice presentation.
Yep. Thank you so much.
Yeah. Any questions from the audience in the chat? In the chat, I do not see a question. I have one question to you regarding the cage placement in the revision cases. Do you remove the hardware first to get a better access when the segment is collapsed and the rod might be in the way?
Yes, in the revision cases, I always remove the implant first and then operation starting like first operation. It means that they have to remove all implant and then operation start again. Always.
Very good. There was another question from Dr. Zatara.
Yeah. So, Dr. Kim, it is fantastic presentation. You have shown very interesting slide that you have shown that for spinal neuro rehabilitation, use the skybox system. So
yeah.
So how it will benefit the patient? What is the idea behind that?
Yeah, actually, the Skywalk system is made by me, and it is not used in another clinic, and because of that, it made by me. But there is a barely advantage to the some nerve damage patient of the weakness. The rehabilitation recovery is very, very rapid. For you see the cases of my cases, the patient near complete pelagic state, but now only 4 weeks later, the patient can possibly by walking by herself.
Interesting.
I have one question.
Yep.
Yeah. Actually, Harrison, do you place the screws first to facilitate distraction of the disk space, or
No,
you
no,
make first interbody fusion?
yes. I believe that some natural restoration of the spinal alignment is first. Because of that, I'm not insert the screw first. I'm insert KG and bone chip first. Then make try to the spontaneous restoration of the spinal alignment by the patient self.
Okay.
Natural correction, I like it.
I have another question. The sheath you introduce, you said that first you introduce it and protect the exiting and transversing nerve root. Do you see the tips of that bevel sheath endoscopically, or do you place it under fluoro?
Fortunately, we performing the dissectomy first. Because of that, we can insert the object to their disc space. Then
but you rotate it, right? You rotate it. You have the tips are first.
My glider follow the operator that inserted already inserted into the disc space. That means that there is a safe area, and then insert first. Yeah.
Okay. And what's the diameter? What's the diameter of that tube?
Tube maybe 12, maybe. But you can push it and decreasing some more.
Yeah, but I mean that.
And also KG, I usually use the KG, maybe KG size usually 12 or 13 millimeter, and sometimes I use some 15 millimeter KG insertion is possible.
So the inner diameter of that tube with the tips is also like 15 millimeters probably, that you can fit.
Yeah, tube size maybe increasing and decreasing is possible.
Yeah.
Yeah.
Okay. Very good. Very nice. Do you think that when you see the disc space and when you see the end plates and prepare them, that this is the success for the high fusion, or is it mainly related to the cage?
Please question again.
Do you think that because you see the end plates endoscopically and you can prepare the end plates endoscopically and flush everything out with the irrigation, that this is the key for the high fusion rate, or is it more related to the cage design itself?
Yeah, it may be high fusion rate, maybe some related to not only endoplate generation, but there is some very big advantage. But there I already mentioned that the 3D printed cage is also very important. Fortunately, using this process, maybe substance rate is very, very low.
Mm-hmm.
Screw fail, cage fail is very low.
Okay.
I
Good.
have a last question. Could you do you find any difference between the placement of a cage between 3445 and L5S1? Because there are some troubles when you try to do to drill the ascending facet in the L5S1. It comes the transfer to nerve root, and it's really difficult to place a cage with this form. So I always use like I remove the flavum ligament and I try to use the same way that I use when I do bleach surgery. Do you do the same in endoscopic spine surgery, or is quite different?
Yeah, currently, I believe that the indirect decompression, I already published the paper in the Neurospine maybe last year. Currently, decompression case, central decompression is so rare. Mostly only insert the cage only in the transperineal space. And also, your question is that like the maybe I always use the 2 kg in the L5 and L5S above level one kg because of that the primary space is above is so narrow and below L5 and L5S is so wide the primary space because of it we can insert the 2 kg insertion is sufficiently insert is possible. But and also using this technique we can decrease the substance rate more sufficiently.
Thank you so much.
Very good. Okay, I think we continue.